So Dr. Vishali will be talking on clinical signs do not corroborate with the lab investigations. So how do we proceed then?
What are the probable scenarios that you would have this situation sitting in the clinic? First is, it could just be the wrong labs were ordered. So, you have a patient which looks like toxoplasma, but somehow you ordered or somebody else ordered CMV titers from the blood. Now CMV comes positive. What will you do? Nothing. CMV was not even required. So just ignore the labs. The second is the lab investigations were ordered, which were non-standardized, and it used to happen a lot with TB. ELISA for TB positive. Probably everybody is positive, but it's not the standardized lab. So just ignore labs. The third scenario is that lab results have arrived when the patient is already responding to whatever treatment you were giving. And like you were treating it, say for example for toxo, and the patient is responding and now the TB comes positive. Would you treat? No, you will not treat because patient is responding. So you would ignore the labs again. And fourth is the lab results are equivocal. You are not sure whether they are good, bad, or how to interpret. Just investigate further, but do not panic simply because you have one lab report positive from somewhere and initiate the patient treatment. So the moral of the story is treat the patient and not the labs. How do you go about it? The first example is the labs were ordered in a wrong setting. Now this is the patient who first presented to our colleagues in private practice. So this was the scenario. The patient was ordered test for TB. PPD came out to be positive. So patient was started on anti-TB drugs with steroids. So when they gave steroids and anti-TB drugs, there was no response. There was increase in this yellowish area and there were this exudative detachment inferiorly, both the eyes. What went wrong? This is not choroiditis. Choroid has an anatomy which can either be focal or diffuse. Choroid will not get inflamed in a linear pattern like this. This is the deposition of fibrin. And when you do fluorescein angiography, you see multiple points of leak which are hyper and increasing in the late phase. Choroiditis active will be hypo to hyper. These are expanding dot signs. Now the expanding dot signs in both the eyes, they are evidence for fibrinous type of CSC or CSR, which was commonly called central serous chorioretinopathy. So this was the wrong scenario to order the labs. Why would you order labs for a patient with CSC? Now the patient has come positive with Monteus, so you give him treatment. What should you do? You should ignore these labs or rather not order in the first place. So what we did, we simply stopped anti-TB drugs. We simply stopped all the steroids. And this is how patient responded. In both the eyes, the fibrin kind of resolved and fluid disappeared. The second scenario is the lab that you have ordered a standard test or not? Because many physicians take decision based on serology and other tests which should not have been done because their positivity does not mean anything. And the examples are antibodies against CMV, herpes, or serological test for TB. So if you have a patient who is walking around with these tests, please, these tests need to be ignored. Now this is a 24-year young girl who has multiple scotomas. She is a myope, and as you can see here, these are the lesions which are very suggestive of PIC, that is punctate inner choroidopathy. And this is how the OCT shows. PIC is very common in myopic women, young women, and this is very typical, where you have RP elevation with sub-RP hyperreflective signals, subtle outer retinal disruption, intact Brooks membrane. Now patient is carrying the report of high titers of CMV IgG. Just ignore it because they don't have any relevance in this scenario? Your diagnosis is PIC. Why should some XYZ lab make you change your diagnosis or make you start antiviral therapy? The third scenario was lab results have arrived when the patient is already responding to whatever treatment you started, because many times in uveitis, some of the labs take about 2 to 3 weeks to respond, and by that time, either you would have given some primitive therapy or the disease would be showing its course. So if it is responding to whatever you did in the beginning before the lab results came, and the lab results indicate something different, don't change. This is an example of a 23-year-old man who came with healed multifocal choroiditis in one eye and active granuloma. The visual acuity was hand motion, tuberculin skin test positive, CT chest normal. So he actually underwent a diagnostic vitrectomy. This was the fluorescein showing increased leak from the granuloma. And 1 week after vitrectomy, his vision was improving and he was on ATT. Now PCR from the vitreous, because we send it for everything, comes positive for toxo. Would I change it to toxo? No. I would just doubt whether it is a false positive test, because if you can see, the patient is already responding to our anti-TB drugs and whatever we have done. So if the patient is responding, do not change your results based on this. So we continued. As you can see, the patient continues to respond to therapy. So lab result could be just wrong. The fourth is investigate further based on the labs, but do not initiate treatment yet. If you really feel lab results have some meaning, go further. Now, this is a 60-year-old woman who was symptomatic for 6 months. Vision is 6/18 in the right eye and counting finger in the left eye. She had aqueous and vitreous cells in both the eyes and was being managed on azathioprine and steroids. There was not much difference. So you can see these multiple granulomatous capes, inflammation, vitritis. So aqueous tab comes positive for tuberculosis PCR. However, patient gives history 5 years earlier. She had undergone Whipple's procedure for periampullary carcinoma, and she carcinoma was restricted to duodenum, and this is the reports that we got from her. So this is the case where you are not really thinking of TB, you are thinking of masquerade, test for TB comes, but there is a granulomatous inflammation and your oncologist says the malignancy is taken care of. So these are the kind of scenarios where you will not hurry to start anti-TB drugs simply because the Montius is positive, but still it could again be TB in a patient with treated cancer. So you would wait and investigate further to see what it could be. So PCR for CMV was also positive, and then when we did IL-6-10 ratio, it showed increased IL-10, which was indicative of malignancy rather than inflammation. So we persisted, we went on to diagnostic PPV, which showed malignant cells, and then we ordered MRI, which shows there was metastasis from the primary disease. So if the investigation in scenario 4 puts you in doubt, investigate further, but do not jump on to start treatment if you are not very convinced about that lab result. And lastly, which is the dictum, treat the patient and not the labs. Thank you very much, Reema, for the opportunity.
Thank you, ma'am. So these cases were wonderful. I'm sure you've learned a lot on how to just pay attention to labs sometimes and pay attention to the clinicals sometimes. So clinical science, and you have to maintain a balance between what you're seeing and what you're treating.